So what we are going to do, this lecture will be to concentrate only on ST elevation MI, because that is that needs energetic treatment, and the treatment depends upon which stage of ST elevation MI you are seeing. So the ECG recognition and what stage you are in, what is the pathophysiological mechanisms which produce ECG change, and what is the treatment intervention in each one of these stages is important. That's why we are going to see what is happening to the ECG when a coronary artery gets occluded after a few minutes, after a few hours, after days, after weeks and years after a coronary occlusion, how the ECG changes during this period of time. So as you can see that myocardial infarctions, ST elevation myocardial infarction can be produced by the total occlusion of a major epicardial coronary artery due to rupture of a vulnerable plaque, which invites an acute thrombus formation, and the acute thrombus formation suddenly occludes an artery. So the myocardium which is perfused by this acute artery, acutely totally occluded artery, undergoes first injury, then the necrosis. So it is not as if the myocardium undergoes necrosis as soon as this coronary artery gets occluded totally. It takes around 6 to 12 hours for the myocardium to become permanently damaged. So that is a window period. So that is the advantage you have. You can open up an artery before this myocardium undergoes a necrosis. Once the myocardium undergoes a necrosis, it's a scar. It will not take part in the contractile process, so it will remain as a scar. After that, you open up an artery with a huge stent of 1.5 lakhs. You will be improving the blood flow to a scar. So it will not get back the myocardium. So that's why you have to intervene before this myocardium undergoes a permanent necrosis. That is the importance of early reperfusion therapy in ST elevation MI. So there are 4 phases of ST elevation MI. Early hyperacute phase, fully evolved. This occurs within minutes and hours of myocardial total coronary occlusion. Then fully evolved acute phase, which occurs after 2 to 3 days of coronary occlusion. Subacute fully evolved phase, which occurs after 1 or 2 weeks of coronary occlusion, and chronic stabilized phase occur after few months and years and continue to be there for years to come in acute myocardial infarction. So these are the 4 stages. Each one of these 4 stages have got different ECG manifestation and different type of approach in the management. So first we look at the most important phase, which is an early hyperacute phase. We already told you there is a total occlusion, so no blood flow is flowing through the distal myocardium. So the myocardium which is perfused by this artery first undergoes an injury. So it is not as if it is going to have straight away infarction. So first few hours, this myocardium has got no infarction at this point. So it is only injury. What injury? Because it's a total occlusion, an epicardial injury, subepicardial injury. So subepicardial injury produces what? ST elevation. So early hyperacute phase is manifested by significant ST segment elevation without a Q wave. Please remember that. At this point, the QRS is normal, indicating that the myocardium is viable but injured. So opening an artery at this point in time will preserve the viability and prevent a myocardial infarction. That is the importance of early reperfusion in early repeated phase. So there are 3 ECG signs of early hyperacute phase. There are 3 ECG signs. One is a slope elevation of ST segment. Second is ST segment elevation with concavity upwards with upright T wave and reciprocal depression. So there are 3 signs by which you can identify the early hyperacute phase. The earliest sign of an early hyperacute phase, or the earliest sign of subepicardial injury, is what is known as a slope elevation of ST segment. Normally I told you the ST segment merges with the T wave with a gentle concavity upwards. The earliest sign is not ST segment elevation, just like I told you about the earliest sign of subendocardial injury. It is not depression, it is a horizontality. Similarly, subepicardial injury, the earliest sign is the ironing out of this concavity. You can see that concavity, you can see it here. It is an ironing out. So what happens is the ST segment as a slope takes off from the end of the Q wave or QRS complex to the peak of the T wave. With ironing out of this concavity is the earliest sign of subepicardial injury. Within minutes you are going to have this change. No elevation. It is only the slope elevation. Many times this is missed. The patient comes to you with half an hour chest pain, you take an ECG, here apparently the ECG will look normal because there is no significant elevation, there is no significant depression. It is only the subtle sign of the ironing out of this concavity, which is called slope elevation of ST segment. It's a very early hyperacute phase. I told you within few minutes of the total coronary occlusion you are going to have this change. Look at this ECG here. What is your diagnosis? What injury this is? Subendocardial injury. What treatment you will give? Heparin or aspirin. So this is what happens. So you see that V5, V6 and L2, L3 AVF. See, compare your ST segment of the V4 versus V5 and V6. What's happening? See that L2, L3 AVF, see the L3 AVF, there is a minimal ST elevation there and ironing out V5, V6. So it is actually a earliest infralateral myocardial infarction. And why this ST depression V1, V2? Reciprocal. So this ST elevation is happening posterior also. When it is happening posteriorly, the V1, V2 showing ST segment depression is not a sign of subepicardial injury. It is a reciprocal sign of a subepicardial injury. So what treatment this patient needs? Thrombolysis. So that's what, if you miss this subtle sign, you will think it is a subendocardial injury and will not expose. The patient is a huge subendocardial, early stage of infarct. His inferior wall is affected. If inferior wall is going to die, lateral wall is going to die, posterior wall is going to die. Because it is acute occlusion which is producing earliest sign of slope elevation. So just compare the segments between, you see that you can compare it nicely here. You see that ST here, V3, you see that ST here. So that is the earliest sign of very early hyperacute phase of subepicardial injury, a slope elevation of ST segment. So that's why I told you, for a chronic old inferior wall infarctions, I asked you to look at V1 to diagnose a tall R wave for posterior wall infarction. Whereas in all acute inferior wall infarctions, where there is a ST elevation in inferior wall, you must also look at V1, V2. For what? ST segment depression. So whenever in early hyperacute phase, ST segment elevation is there in inferior leads, V1, V2 shows ST segment depression. It tells you what? There is also posterior ST elevation. So that's what I told you, whether it is acute or chronic inferior wall infarctions, first look at the chest leads. In inferior wall infarction, everybody looking at the inferior leads. You must look at the chest leads. In a chronic inferior wall infarction, V1 showing a tall R wave tells you that's a chronic posterior wall infarction. Whereas in acute inferior wall infarction, V1, V2 showing ST segment depression tells you it's a reciprocal change of a posterior ST segment elevation. So I have additional posterior wall involvement if you see this sign. So this is infralateral posterior MI, early hyperacute phase. So once you miss this stage, the patient can come to you with a classical ST segment elevation. Here, the hyperacute ST segment elevation is different from a ST segment elevation of subsequent phases like fully evolved phase, in that the ST continue to remain with the concavity upwards. ST is elevated but continue to remain with the concavity upwards with the upright T wave. So because the R wave is upright, the ST segment gets elevated like this. So this is the second manifestation of the hyperacute phase, ST segment elevation with the concavity upwards. So you can see it here, the inferior leads. The ST is elevated here nicely, but the T wave is upright, concavity is maintained. So this is a early hyperacute phase. What is a single sentence diagnosis for this ECG? Acute occlusion of RCA. So once you record the inferior wall elevation, what you must see? V1, V2. V2, you see depression. So what's happening? Posterior infarction. This is what you must know. So inferior wall is obvious. You must also diagnose a posterior wall involvement. So the treatment you give for this ECG will be as soon as possible. So thrombolysis as soon as possible. So this is ST elevation with concavity upwards, so indicating the posterior wall infarction. So the patient should be thrombolized immediately. So it's acute total occlusion of right coronary artery. So the third important change of a hyperacute phase is called what is known as a reciprocal depression. So reciprocal depression is nothing but the same principle we have told you right from the first lecture, that if an impulse goes towards an electrode, this electrode will be positive, going away from the negative. So when the ST elevation is happening through the group of leads, certain group of leads, the ST elevation is coming towards that group of leads. For example, in this ECG, the ST elevation is there in inferior leads, means ST vector is coming towards inferior leads. That's why ST elevation is there. When it is coming towards inferior leads, it is going away from which leads? When inferior leads, what is the opposite of inferior leads? L1 AVL, your superior leads are L1 AVL. So if the ST is going to come towards your inferior leads, it is going to go away from your superior leads. So superior leads will show what? ST segment depression. So that's what, whenever you have an ST segment elevation, L1 and AVL showing a ST segment depression is called reciprocal depression, which indicates ST vector acutely coming towards inferior leads and going away from your high lateral leads. So the reciprocal depression, the posterior ST depression, here you see, is a reciprocal depression of posterior ST elevation, isn't it? The ST depression you see in V1, V2 is once again reciprocal depression. The posterior is showing the ST elevation. That means the ST is going towards posterior leads and it is going away from your anterior leads. That's why V1, V2 shows ST segment depression. So what you see in V1, V2 is once again a reciprocal depression. In a classical inferior wall infarction, you will have reciprocal depression in the opposite group of leads, that is L1 and AVL will have ST segment depression. So there are three important signs of early hyperacute phase is, so when the inferior leads are ST elevation, the L1 AVL will have a ST segment depression, which is called reciprocal change. As you can see in this patient, so when you have this ST segment elevation here, L1 AVL showing a reciprocal depression, V1, V2 showing a ST segment depression, V3 showing the reciprocal depression of posterior wall here. So this is a reciprocal depression of posterior wall, this is a reciprocal depression of inferior wall. So inferior wall reciprocal depression in L1 AVL, posterior wall reciprocal depression will be in V1 to V3. So this is the third important sign of early hyperacute phase. So hyperacute phase, at this point it is totally injury only. There is no infarction. That's why in all these ECGs you can see that here ST is elevated but the QRS is normal. Similarly in this ECG you can see that ST is elevated, you see the QRS is normal. Still the R wave is very well there. What does it mean? At this point this myocardium is injured but not dead. So if you are able to open up an artery and restore the blood flow to this myocardium, you continue to preserve an R wave, which is the sign of viability. You will not allow this R wave to go for Q wave in inferior leads, which means you have allowed the infarct to happen and necrosis to happen. That is a permanent change. After that you cannot change it. So that is the importance of opening up an artery at this stage itself. At the importance of recognizing this particular ECG change in this. So whenever you have an acute chest pain patient coming to you, so first you have decided it is an acute coronary syndrome, ST segment elevation or depression, the first thing you must give will be 325 milligram of soluble aspirin plus a clopidogrel of 300 milligram before you transfer. For example, you are seeing a patient in your peripheries or in your hospital or your clinic, you have taken ECG and the ECG shows either ST elevation or depression, but you have decided it is an acute coronary syndrome. You are going to transfer the patient to some other hospital for thrombolysis or for further treatment. You give these two drugs and then only transfer. 325 soluble aspirin, 300 milligram clopidogrel. Please do not give heparin if it is ST elevation MI. Please remember, because ST elevation MI he is going to thrombolyze. So if you give heparin, you will be confused whether to thrombolyze or not and so on. So if it is ST elevation MI, you do not give heparin. Whereas it's ST depression, subendocardial injury, the treatment is going to be heparin only. So you can give heparin, 1 dose of heparin and send if it is a subendocardial injury. So if it is subepicardial injury, ST elevation, don't give heparin. Do not give entry-coated aspirin. You must give always 325 milligram of soluble aspirin. That's why I always advise all our practitioners to have aspirin on their table. 325 milligram of soluble aspirin, not entry-coated aspirin. So whenever the patient comes with acute chest pain, you diagnose a myocardial infarction, give the aspirin, because aspirin and clopidogrel are poor man's thrombolytic agents. They are poor man's thrombolytic agents. By giving aspirin and clopidogrel, you are starting the process of restoring the blood flow, lysing the clot. Then the heparin can be given if there is a ST segment depression. Sedation, morphine is the best. Don't routinely give sublingual nitrate. Only when the heart rate is between 50 and 100 per minute and your systolic blood pressure is more than 90 to 100, then only you must give sublingual nitrate. Routinely, all chest pain patients without checking the blood pressure do not give a sublingual nitrate. Please always ask for the history of sildenafil. The patient has taken sildenafil prior 24 hours, you are not, even if it is an acute coronary syndrome, you are not supposed to give a sublingual nitrate for that patient. So this history should be asked before we give a sublingual nitrate. And of course, when the patient, you are not treating the patient, you must not keep the patient in your hospital. Keep on giving sublingual nitrate. By the time you close the clinic and go to the hospital, give a reference letter and send the patient. So if you decide it is an acute coronary syndrome, within 30 minutes of the entry of the patient into the hospital, the patient should be referred immediately to the referring institution. So by that time, once again, when you give a referral, it is not as if you give just a letter referral and ask the patient to go. Many patients may not go. They will go to the house, find auspicious time and day, and go to the temple. By the time they go to the doctor, they directly go to the God. So instead of going to the doctor, you would have reached the God straight away. So you must motivate the patient, especially ST elevations, motivate the patient to go immediately and alert the institution that this patient is coming, he is eligible for thrombolysis, be ready. Because many times you give a letter that cardiologist is gone for a vacation, this fellow go to the hospital, the cardiologist is not there, so you go to the next hospital, that cardiologist is not there. See, with the ST elevation MI, he will be going around. So you must send, motivate and alert the referring institution so that he does not have any delay once he reaches the hospital. Because you have already given heparin, already given aspirin, clopidogrel, you have diagnosed ST elevation MI, you know he is eligible for thrombolysis, so you always brief the tertiary doctor, he is ready. So as soon as the patient enters hospital, within 10 minutes the thrombolysis is done. So this way we can significantly reduce the time delay of the patient chest pain and the reperfusion therapy. So this is the concept of referral. So nowadays, if the patient comes to acute chest pain, within 2 hours into the hospital, if the hospital is capable of doing a primary cutaneous intervention, primary coronary intervention, that is the best for thrombolytic therapy. Because the best of thrombolytic therapy, even given within 1 hour, cannot open up an artery more than 70% of times. Best of thrombolytic therapy, given best of times, cannot open up the artery more than 70%. Whereas when you do a PCI, 98 to 99% you open up an artery. So that is the best mode of treatment for ST elevation MI, no doubt about that. So when the patient comes to acute chest pain and it is capable, PCI capable, must do a primary PCI within 90 minutes of the patient's entry into the hospital. For example, patient comes to a non-PCI capable hospital, you are not doing PCI, but your institution within the next door or within the next street, an institution is there, where the PCI can be done within 2 hours of your contact, within 120 minutes of your contact, less than 2 hours, they must do a PCI, refer the patient straight away PCI by giving the aspirin and clopidogrel, and if is eligible, sublingual nitrate. So this is the best mode of treatment. Within 2 hours it is done, it can be done PCI. If you are not PCI capable hospital and you do not have a hospital in which you can do a PCI within 2 hours, you thrombolyze yourself. Do not refer to an institution where the patient has to travel for 4 hours and that fellow takes another 4 hours for PCI, whereas you can thrombolyze within 30 minutes. So that's what important. So if you are able to, if the delay is going to be there for PCI, thrombolyze the patient. So that is important. So if the PCI less than 2 hours is not possible, if you are thrombolyzing, thrombolyze yourself or refer the patient to a nearest CCU where the patient gets a thrombolytic therapy. So this is the concept of ST elevation referrals. What to give, where to send. So this is very important for early thrombolytic therapy, early reperfusion therapy. Why in ST elevation time is muscle. The morbidity and mortality due to ST elevation MI can be reduced significantly if the patients are coming immediately after the chest pain. The primary care practitioners recognize symptoms, are able to read the ECG, diagnose an acute coronary syndrome, give appropriate drugs and refer the patient to an appropriate institution for an appropriate revascularization therapy. Then of course we can significantly reduce the mortality and morbidity. Most important is morbidity. The ST elevation MI you may thrombolyze after a few hours or PCI doing after 12 hours. The patient may survive, but he may survive with V1 to V6 Q wave. He will survive, but what happened? His myocardium is dead. V1 to V6 Q wave means no healthy myocardium. So he will be living with recurrent episodes of heart failure. It is good for you because the patient every month he will come and get admitted 3 or 4 days IV diuretic therapy and go on. Good for the hospital, but not good for the patient. So it is, what is the important in ST elevation MI is not only save the life of the patient, but the myocardium of the patient. The patient has to live with a good healthy myocardium without recurrent episodes of heart failure. For that, the only key is early revascularization therapy. So any good hospital should do a thrombolytic therapy, which is called door to needle time. The patient enters the door of the hospital, needle is inserted for a thrombolytic therapy within less than 30 minutes. Good hospital. Excellent hospitals thrombolize within 15 minutes. So be an excellent hospital, try to thrombolize within 15 minutes of the patient's entry to the chest pain. The PCA capable hospital is called door to balloon time. Patients enter the time of the entry of the patient to the balloon is inserted, not the cath lab. The patient is going into the cath lab. The patient has to go to the cath lab, angiogram is done, and the balloon is inside the coronary artery for inflation within 90 minutes of entry into the hospital. So this is the reperfusion goal in any hospital. 30 minutes, no to needle time, less than 30 minutes, but be an excellent hospital, do it within 15 minutes of entry into the hospital. Because if you thrombolize within 1 hour, you can leave 65 lives. If you thrombolize within 6 hours, you will save only 30 lives. If you thrombolize after 12 hours, you will save only 10 lives. So it all depends upon the reperfusion when you do the reperfusion. So you can see that huge ST elevation MI. What's happening here? The huge ST elevation here, V1 to V6, L1 and AVL. That is entire anterior wall, interventricular septum, anterolateral wall, high lateral wall are injured. That is the entire left ventricular myocardium is going to die in this patient. But at this point in time, see the R wave there. That means at this point in time, there is no infarct at this time. So you thrombolize the patient within 30 minutes or 15 minutes of this hospital, entry into the hospital. You can see the next ECG of the patient after 1.5 hours. See such a huge ST elevation has come to this type of ECG, where the R wave is continued to be preserved, V1, V6, L1 and AVL. So everything you have saved because the early thrombolytic therapy. So you can see at the time of discharge, the patient has got near normal ECG. The fellow who came with this type of ECG can go with this type of ECG if you are able to intervene early. So that is the importance of hyperacute phase. I spent considerable time on this because it's the most crucial phase and every one of you must recognize it early and also give appropriate treatment and referrals with the appropriate treatment. Then after a few days, this is the early hyperacute phase is within hours of total coronary occlusion. So what's happening after second day or third day? Let us say the patient comes to you after 3 days of chest pain. He had chest pain on Friday. He is coming to you on Sunday. What will be the ECG change and what treatment you are going to give? So this is called fully evolved acute phase. So within days of coronary occlusion. In this phase, portion of myocardium has been already necrosed and there is a development of pathological Q wave which represents necrosis. So what's happening here is, see, imagine in your acute hyperacute phase, everything is injury. So after some time, if the coronary artery is not opened up, or you have given a thrombolytic therapy which has partially worked. Many times the thrombolytic therapy may not work totally. You may not totally prevent a myocardial infarction. What the ECG I showed is a rarity. Many times the patient may come to you with a huge infarct territory, but you may be able to limit it. For example, L1 to AVL you have ST elevation. The patient may after thrombolytic therapy will have a Q wave V1 to V3. V4, V5, V6 you may be able to save. At the most of the time you will be able to limit the infarct size rather than prevent an infarction. So that's what usually happens. So what happens is the thrombolytic therapy, after thrombolytic therapy, or the patient does not come for the early stage, everything is injury in hyperacute phase. The central area of this injury undergoes an infarct change. The central area dies. So it becomes a necrosis. The some area surrounding that, the core, central core area, continue to remain in injury. It is not gone in for infarction, it has not recovered. Whereas the periphery area, that is periphery territory, will recover from injury because of the collateral circulation which is coming and go to the previous stage of coronary manifestation of ischemia. So what happens in early hyperacute, in fully evolved acute phases, there is a central area of necrosis, surrounding area of injury and peripheral area of ischemia. So this is a very important stage because here is the only stage in which you see all the three manifestations of coronary heart disease. What are the three manifestations of coronary heart disease? Infarction, injury, ischemia. In a single ECG, you will see all the three only in this phase. So please remember, early hyperacute phase, then after 1 or 2 days, some area undergoes necrosis, some area continue to remain injury, and peripheral area recovers from injury to ischemia. So what are the manifestations? The central area of necrosis will produce what? Pathological Q wave. The surrounding area of injury will produce what? Continue to produce injury ST elevation. The peripheral area of ischemia will produce what? The T wave inversion. So net result, the patient will have a pathological Q wave, ST segment elevation, and the T wave inversion. The difference between early hyperacute phase and this phase of ST elevation is the contour of ST elevation. There I told you ST elevation is concavity upwards because the T wave is upright. Here, because the T wave gets inverted, what it makes is, it makes the ST elevation convexity upwards. So now you see the ST becomes convexity upwards and you have the T wave inversion. So this is a fully evolved acute phase where you see the necrosis, injury and ischemia. So this is the stage on which you give patient heparin, continue to give dual antiplatelet drugs, start him on AC inhibitors, beta blockers, high dose statins. So all these drugs. Here your object is to stabilize or heal this myocardial infarction, stabilize this myocardial infarction, prevent further extension of infarction, stabilize this injury by restoring the blood supply through heparin and so on. So don't give thrombolytic therapy at this stage. You should not give thrombolytic therapy. Why you should not give? Already necrosis is there. So the main purpose of giving thrombolytic therapy is prevent an infarction. The patient is coming after 3 days and it's already a necrosis happened. There is no need to give thrombolytic therapy at this stage. Only heparin, dual antiplatelets, AC inhibitors, beta blockers and statins are the treatment of choice in this space. So you can see it here. The patient has got, see, V1 to V3, V4. You see that SC segment? Nice convexity upwards and the T wave inversion. There is no R wave. V1 to V4, there is no R wave at all. That means V1 to V4 totally dead. The scar has come and this elevation is injury, convexity upwards now and the T wave inversion. So this is a fully evolved acute phase after 2 to 3 days of myocardial necrosis. Now we go to the next stage of fully evolved subacute phase. In fully evolved subacute phase, what's happening is you are giving the treatment very nicely. You are giving heparin and the patient is made to rest and all infarct limiting drugs are given. The aspirin, AC inhibitors, beta blockers are given. So after a week, the fully evolved subacute phase is after a week. So what happens is, because you are giving heparin, antiplatelet and so on, there is some amount of restoration of blood flow, opening up of collateral arteries. So what happens is, in a fully evolved acute phase, you had infarction, injury and ischemia. Because some amount of blood flow is restored, that injury area also go into the next stage or the previous stage of coronary artery disease manifestation of ischemia. So that injury area recovers and go into ischemia. But of course the central core of necrosis cannot be altered. So the control area of necrosis continue to remain as Q wave, whereas your ST segment elevation now settles down. Why it settles down? The injury is healed. The injury is managed because of the restored blood supply. Very good drugs like AC inhibitors and statins, heparin and antiplatelets, trying to open up some amount of blood flow to the myocardium, which is an injured myocardium. So the injury stage gets healed. So the patient is left with fully evolved subacute phase, central area of necrosis and only surrounding area of ischemia. So at this point in time, the injury area has gone. So you have a central area of necrosis which will continue to produce a Q wave, a pathological Q wave. The surrounding area of ischemia, you can see that surrounding area of ischemia will produce the T wave inversion. So at this point, the ST settles down, isn't it? The ST settles down because the injury is cured, injury is treated. So this is the stage on which you discharge the patient. Because the acute change, what is the acute change? ST. ST has stabilized. So the patient is left with infarction and ischemia. So this is the stage on which you discharge the patient. Discharge the patient with what advice? You never discharge a patient with acute coronary syndrome without these 5 drugs. One is dual antiplatelet drugs. Second is a beta blocker, preferably metoprolol or carvedilol. Third is an AC inhibitor, preferably ramipril or perindopril. Fourth is high dose statins. So the checklist at discharge should contain all these 4 drugs if there are no contraindications. Of course, if there are contraindication, you cannot use certain drugs. If there are no contraindication, you cannot discharge the patient without these 5 drugs. And also at this point in time, you decide whether the patient will need a revascularization, whether he will need an angiogram, depending upon what type of complication he had during the acute phase, whether he had an angina during the acute phase, whether he had recurrent chest pain during the acute phase. So at this point, you also decide whether the patient should go for the coronary angiogram and revascularization, or he may maintain on medical therapy. So at time of discharge, you have to decide on that risk factor modification, discharge with these 4 important drugs, so that you will prevent next myocardial infarction. So this is a fully evolved subacute phase where the injury is treated, the patient is discharged with the infarction and Q wave. So the patient becomes a Q wave, ST isoelectric T wave inversion. So I can see this ECG here. The patient V1 to V4. Now he has V1 to V4. There is a Q wave here, pathological Q wave. There is no R wave there. And you see the ST there? ST is at the baseline. So there is no ST elevation here. That means this is fully evolved subacute phase. Because you have treated the main aspect of the acute phase injury, you discharge the patient. For example, why this is all important? For after 7 days, the ST has not settled down. You expect the ST to settle down around, by the 7 days or 10 days, you expect the ST to settle down, you discharge the patient. For example, you continue to have ST elevation. The patient has continued to have a coving ST segment elevation even 7 days, 8 days. The ST is not settling down. Then you must go into the causes of why the injury is not getting cured. Whether it is ongoing ischemia, whether it is a significant LV dysfunction and aneurysm, or there is a pericarditis. If the patient has got a pericarditis, ST will not settle down. So you must go into the causes of why there is a persistent ST elevation even after some time where it is expected to settle. So that's why the evolutionary changes is important to see why it is not happening. You must know, you must see why it is not happening and treat that appropriate cause. So this is a fully evolved subacute phase where there is a Q wave, normal ST segment and the symmetrical. See the T wave inversion. You see that now? It's a classical primary T wave inversion. See the ST segment flat and symmetrical T wave inversion. So this is the ischemia. Then you are treating the patient for months and years with a meticulous care, taking care of all his risk factors and controlling him. What happens? You are discharged with an ischemia and infarction. So by the time, after months and a few months, what happens? The ischemia also gets cured, isn't it? The ischemia gets also cured. So what happens now? There is a central area of necrosis remain which you cannot alter. The ischemia also gets cured because of your continuous therapy and risk factor modification. So in a chronic stabilized phase, the patient is left with only the Q wave, ST is normal, T wave is normal. Because there is no injury, ST is normal. Because there is no ischemia, the T wave is normal. So this is a chronic stabilized phase of myocardial infarction. So the treatment at this phase is to prevent the next infarction. So at this stage of the patient, the object is to prevent another infarction by taking care of good secondary prevention. So the central area of necrosis is going to produce a pathological Q wave. So there is no surrounding area of ischemia. There is no surrounding area of injury. So the patient is left with only the central area of necrosis, the Q wave, and the treatment of choice is going to be secondary prevention. So the Q wave, normal ST and the normal T wave is chronic stabilized phase. So you can see it in this ECG, you can see in inferior leads, single sentence diagnosis. Single sentence diagnosis, quick. Chronic stabilized phase, okay. Chronic total occlusion of RCA. You can see that pathological Q wave is there, the ST is normal and the T wave is normal. So this is what happens. There is no injury, there is no ischemia. So it is only the necrosis remains, the scar remains. So here your job is to prevent a next myocardial infarction. So in early hyperacute phase, total occlusion, only injury. In acute fully evolved phase, central area of necrosis, surrounding area of injury, surrounding area of ischemia. In fully evolved subacute phase, central area of necrosis, surrounding area of ischemia. In chronic stabilized phase, only infarct area. So if you translate that into ECG signs, early hyperacute phase, ST elevation, 3 signs, slope elevation, ST elevation concavity upwards and reciprocal depression. Fully evolved acute phase, all the three ECG signs, necrosis Q wave, injury ST elevation with convexity upwards, and ischemia T wave inversion. In a fully evolved acute phase, the injury settles down, ST segment is normal, the Q wave with a T wave inversion. So this is a resolution phase. And in a chronic stabilized phase, the Q wave, no injury or no infarction. So this is the evolution of your ST elevation MI, of ECG signs, and each stage what you are supposed to do to make the patient better. Then I'll give you a concept of the recent concept of what is known as a non-Q wave myocardial infarctions. Non-Q wave myocardial infarction. Sometimes what happens is it's not as if without our interference, or sometimes in spite of our interference, the patient may become better. So that's what happens. In spite of our interference also, the patient may become better. So this what happens is whenever there is an acute occlusion, it's not as if always you have to give a thrombolytic therapy to open up an artery. There is what is known as the spontaneous thrombolysis or a spontaneous fibrinolysis system. Our own system may lyse our thrombus, which is happening inside the coronary artery. So whatever thrombolytic therapy you give, like streptokinase or tenteplase, how do they act? They act by converting your plasminogen to plasmin, and it is your own plasmin which is going to lyse the clot. It is not as if your streptokinase is going to lyse the clot. It is not connectoplate which is going to lyse the clot. What these drugs do is to stimulate your fibrinolytic system, and it is your own fibrinolytic system is going to lyse the clot. So some people, the formation of thrombus inside the coronary artery itself is a stimulus for the stimulation of our own endogenous fibrinolytic system to get activated. This fibrinolytic system will go and open up an artery. Even without you are giving a fibrinolytic therapy, they will open up an artery. So when that happens, what happens? The patient will have acute chest pain and the fibrinolytic system gets activated and gets opened up. Most often when it gets opened up, it will open up immediately or sometimes after. It will prevent an infarction. It will prevent an infarction. So the patient will not have a Q wave because the artery is opened up before the infarct has happened. So, but some amount of ischemia will be there because the artery occlusion is there, some amount of ischemia will be there. So some patients, what they do is, when they come to you after 2 to 3 days of chest pain, they will not have Q wave, they will not have ST elevation, they will have only symmetrical T wave inversion, which indicates significant ischemia. So they will come with you with no chest pain. 3 days back they had chest pain. When they come after 3 days, you expect them to be in acute fully evolved phase. You expect them to Q wave, ST segment elevation, T wave inversion. But some patients may come to you without no Q wave, without any Q wave, no ST segment, only symmetrical T wave inversion. What's happening here is the acute occlusion which has happened before it opened up with our own system would have produced what is known as a microinfarcts. Small microinfarcts here, which will be manifested as a significant subepicardial ischemia. And the patient with after 2 to 3 days, they are coming to you with this type of T wave inversion. So there is no ST elevation here, there is no Q wave there, but only symmetrical T wave inversion, significant subepicardial ischemia. So the 3 days chest pain, the patient comes to you and you do a troponin, and the troponin is positive. Then only it becomes a non-Q wave myocardial infarction. So whenever there is a non-ST elevation situation, for example, it is an ST segment depression or a T wave inversion like this, you should not call them as non-ST elevation MI with the ECG signs alone. The patient should be having a troponin positivity. Only if the troponin is positive, we call them as non-ST elevation MI. For example, in this situation or ST segment depression situation, troponin is negative, we call them as unstable angina. So that is the difference between unstable angina and non-Q wave MI. To call it as an MI, you must demonstrate the enzymes are positive. The myocardium is damaged because of the elevation of enzyme. So any ECG change, any non-ST elevation ECG change with a troponin positivity, it is called non-ST elevation MI. With a troponin negative, it is called unstable angina. When the ST elevation is there, it is ST elevation myocardial infarction. So this is the approach. So this is a non-Q wave myocardial infarction. Why I am spending so much time on this is, many times these patients get admitted, they will have completely uncomplicated course for 4 to 5 days, no complication, no chest pain, LV function is absolutely normal, no signs of heart failure. So you think this patient has got nothing, you would tend to discharge the patient around 7th day. Because the patient did not have any complication during acute phase, you likely to have discharge. But the important clue here is, many times the patients who are coming to you with this type of change, which is a symmetrical deep T wave inversion in V2 to V3, non-ST elevation situation, troponin positive, if you discharge these patients, they will come back within 2 to 3 weeks with a massive ST elevation MI. With a massive ST elevation MI. Because this sign of T wave inversion, V2, V3, which is called valence sign, represent critical occlusion of LAD. It represents critical occlusion of LAD. It's called valence sign. So whenever a non-Q wave MI is having a deep T wave inversion V3, V4, you must immediately send the patient for coronary angiogram. Although this patient had an uncomplicated phase in acute phase, no complication at all, you tend to discharge them around 7th day or 8th day. You should not discharge these patients without a coronary angiogram. Because here, what's happened is, coronary artery got occluded, there is a microinfarct happened, a small amount of blood flow has been restored by our endogenous fibrinolysis system, which has opened the artery only 10 to 15% of your lumen. Still 90% of thrombus is inside. This 90% at any time can go for 100% to have a massive ST elevation MI. So that's why these patients should be subjected to angiogram before discharge. Why it is so? Because you can see the R wave was not preserved. At this point in time, the patient do not have any necrosis. If he is allowed to go for an ST elevation MI and necrosis, you will have a massive left ventricular damage. So before that, it is an opportunity. For example, the patient has got a Q wave. You can do angiogram leisurely because the Q wave has happened. Whereas here, the Q wave has not happened. At the same time, this myocardium is supplied by critically narrowed artery. This myocardium is likely to die if he is going for a ST elevation MI. So this is an indication for an early angiogram. So this is called non-Q wave ST elevation MI. So this is a summary slide. So we have 4 phases: early hyperacute phase, fully evolved subacute phase, and chronic stabilized phase. So pathology is early hyperacute phase is injury. So you have 3 signs: slope elevation, concavity upwards, reciprocal depression, urgent thrombolysis, aspirin, clopidogrel. Whereas fully evolved acute phase, the pathology is central area of infarct, surrounding area of injury, surrounding area of ischemia. Infarct is Q wave, injury is ST elevation, convexity upwards, ischemia is symmetrical T wave inversion. So at this point in time, no thrombolysis, statins, ACE inhibitors, beta blockers, heparin, and dual antiplatelets. So after few weeks, the patient will have a fully evolved subacute phase where the injury gets cured, the patient is left with ischemia and infarct, Q wave, normalization of ST segment, and the symmetrical T wave inversion. At this time, you discharge the patient and decide whether the patient needs a revascularization and discharge with the 4 group of drugs I told you. After months and years, the patient is in chronic stabilized phase. The ischemia also gets cured. So the patient is left with infarct. Only the Q wave, ST is normal, T wave is normal. The treatment is to prevent a next infarction. So this is in nutshell the approach and the evolution of your ST segment elevation and what type of treatment you are supposed to institute in each one of these stages. So the conclusion in 10 commandments in as far as the coronary heart disease chapters are concerned. First, identify the pathology: injury, ischemia, infarction. If it is injury, act fast. Be it subendocardial injury or subendocardial, anything. ST elevation MI, diagnosis by ST elevation, grade of ischemia, and also see which coronary artery is involved, what is the level of obstruction. I told you there are certain signs which will tell you proximal obstruction. Whether there is a remote infarct is there in the form of posterior infarct. Risk stratify according to the ECG change. Look for other complications. Look for viability and rhythm changes and so on. Emergent, energetic, evidence-based treatment will save not only lot of lives but lot of myocardium. The objective is to save the myocardium. A living patient with a bad myocardium is worse than a dead patient for the family. Of course, the family continue to suffer for recurrent admissions and so on. So that's what the importance is. Right.